now you're able to get people in the county under care and they can go into hospital and be treated. How is this working?
First, we prepared a policy that was passed by the Assembly, and the policy now indicates the logic, the rationale, and the structuring of the program. Basically, every year we announce a date to the public and we go and recruit poor people who join the program. And the criteria mainly is vulnerability. So it tends to be uptaken mainly by the elderly. Once you join it, there are a set of benefits that you get. One is inpatient and outpatient free services in public and private hospitals that are aligned to NHIF. Secondly, free optical. Thirdly, free dental care in public facilities. Fourthly, if you are referred outside the country for treatment, you are paid 500,000 Kenya shilling. If you pass on or your dependent passes on, you are entitled to Kenya shillings 100,000 as last expense. Also, emergency evacuation by an ambulance that is affiliated to NHIF. This the first year we had 20,000 households. This year we have 40,000 households. Assuming one household has about 3 or 4 dependents, that's about 160,000 persons who are under this program. Basically, that's how it works.
Okay.
But let me also clarify. We entered into an MOU with NHIF detailing all those points I've stated here.
Okay. So it's benefiting 40,000 households. These are the ones that you've registered as the needy ones?
Yes.
40,000 needy families?
Yes.
How do you identify? What's the criteria for identification of need?
We usually indicate in our poster when you are recruiting the criteria, which is mainly, it's weighted. We come up with a weighting. Let's say if you are an orphan, you get 20 marks. If you have disability, you get 20 marks. If you don't, you get 10. Yeah. The other weight will be diseases. Do you have chronic non-communicable diseases like hypertension, diabetes, mental illness? You get, let's say, 40 marks. If you don't, you get 20 marks.
Disability.
So disability, such.
Okay.
But, and then we recruit per primary school. The idea is to ensure equity. So we tell people to go to their nearest primary schools on a date that we have indicated. Then we give, each school should recruit a certain amount of persons. You'll find, let's say, Murang'a is about 600 primary school. So 40,000 slots divided by 600. I don't know how much is that.
We can find that out.
So,
80.
8. So you say we will on average, each school should give us 8 households. But the truth is, the last time when we were doing recruitment, we wanted to recruit about 30,000 based on our budget. But the people who came out were 43,000. We decided to recruit everyone. So no one
is left behind.
No one was left behind. We said we will maneuver to get resources elsewhere. But the point is no one failed except those who are knocked out on technical grounds. Technical grounds means the people who came for recruitment, so we had a 43,000 long list. Then we took those names to NHIF for onboarding. We realized some, for instance, don't have, the ID is incorrect, or you're already on NHIF without you knowing. There are some people who are in NHIF without their knowledge. You see, NHIF, the way it was structured, it used to have special schemes that are paid for by the governments. I think there was one that I don't know was targeting, I don't know who. Chiefs were told to collect names. So those names were onboarded.
Already.
And the government used to pay for them. But it appears people never used to know they are actually on NHIF. And the reason was, one, poor public education by those governmental schemes. Secondly, NHIF stopped giving out cards, physical cards to manage. So people, you can be NHIF, you don't.
But you don't have
Because you don't have a- you
because
don't
you
need a
don't
card.
have. So as we flipped that logic and give our people a physical card, then we knew that once people get a physical card, that will boost utilization rate. Yeah.
Has it changed that utilization, the hospital visits,
No, they
on account of now that you are covered, are people's health-seeking behavior different?
Yeah, one, of course, definitely people are happier because you see now they know they are well covered. But of course, people don't go to seek medical services on account that they really want. They only go to when they are actually sick. However, there are people before who you never used to go to hospital on account they can't afford. So now this definitely removes the cost barrier to seeking Medicare. But it also brought a challenge, which is people seeking medical services at our level 4 hospitals increased. Muranga, before we came into office, immediately we came to the office, it used to record 700 persons outpatient visits per day. Currently, we are doing 1,500 per day.
Seen and treated.
Seen either. These people never used to come to the hospital. They were just sick and staying at home. That's one possibility. Or because we also automated our health records, maybe there are people who used to come to the hospital, they were not recorded, and they would get service and go home. Now that we are now able to,
You're capturing it.
we are now capturing that, either of that too. But we think there's an element that people used to get sick and not seek service. But of course, now that brings a new challenge that now you have to look for more
money.
To treat those people. The HR component, the medicine, So it has a negative element or a challenge. Let me not use say negative, I say a challenge. You'd imagine 1,500 people seeking services.
You've
in your
increased
facility.
demand, so you must meet that demand.
You must meet that demand. Yeah.
What does it mean then in this transition? Now that NHIF is no more, and you had signed deals with NHIF, have you signed deals with Social Health Authority?
That's a very sharp question. That's a very sharp question, and I think one of the most important questions we have dealt we need to think about. When we were signing that, our current MOU, I think it was in December last year, we anticipated problems. We inserted a clause that indicated that once these changes come into force, we will seek to revisit the MOU. And coming to force means the effective date, the start date of SHIF. It was shifted. It is now set to be 1st of October 2024, the next 2 weeks also. 1 week, by the way, from now.
Yep, it's next week.
Yes. So last week, we went to see NHIF management. We told them, now, look, you guys,
are dead.
We have a problem here.
The funeral is next week.
Now what do we do? There is, in their understanding, they wanted us to continue with Kang'ata Care up to 31st of December 2024. On the basis there's a clause in the new law of NHIF that seems to say any
Existing
arrangement can be saved up to 31st. So they were telling her, you guys, you pay your premiums.
You're sorted.
You're sorted up to 31st of December. But we are not minded to agree to that for several reasons. One, SHIF is cheaper than Kang'ata Care or the older NHIF. So you are telling me to pay. We currently Kang'ata Care pays for one household about per month 820 Kenya shilling. You know, these are what we call enhanced covers. But SHIF says for poor people, indigents, they should pay 300 Kenya shilling. So on what basis do you want me to go to pay for the same service at 820, which is already in place?
For less.
For less. I don't understand. Doesn't make sense. Eh?
So will there be a shift
Yeah.
to SHIF?
I wrote a letter. I think last week I told them, you guys migrate my people from Kang'ata Care to SHIF.
So what happens to the program?
It
Kang'ata
continues. You see, what are they? You know, SHIF. The philosophy of SHIF is that everyone should be treated equal.
Yep.
We don't have two sets of benefits
Yep.
or beneficiaries. So it's like amalgamation. So we are arguing, and by the way, national government, they used to have a civil servant specialized scheme. It has shifted out of NHIF. NHIF owns staff. They were under a certain specialized
They have
scheme.
their own scheme.
It is also been, it is ending by 1st of October.
So all of them are being brought back now
Yeah,
to SHIF.
to SHIF. So I'm saying the same logic. SHIF. You shift my people to SHIF. I pay at a cheaper,
The new rate,
the new rate of
300
300
per household.
per household.
Because it is working.
Well, whatever, it is the law. Why, you see now, surely, assume I continue paying 820.
Yeah.
And 20.
What am I paying for? What's specialized?
There's nothing extra
service?
that you get.
What extra am I getting? There's nothing. There's nothing. Doesn't make sense. There is nothing. So I told them, you shift my 40,000 households to SHIF. I pay you SHIF charges.
As far as you know, with just less than 10.
Let me also just mention, SHIF will give almost, in fact, will give better benefits package.
More benefits.
It's been, except last expense. It doesn't have a last expense component. So that single component, we have externalized it. We did a tender, and a company called Britam won it. We are waiting for the standstill period to end. We sign off. By the way, they have promised us heaven. Because you see, apart from the 100,000 that we shall be giving to members of this scheme, they are proposing to give us welfare packages. That is, if you're under Kang'ata Care, going forward, if you get a child, you get 10,000. I think if you marry, I don't know, 25,000. Yes.
This is what the company is proposing.
Yes.
Britam.
Yes. If you get a child, no. If you get a child, 10,000. If you marry, 10,000. If you have a child going to school, high school, you get 25,000 school fees.
And still, in the event of death, 100,000
100,000. That is the proposal.
for any member of the household.
Yes, any member.
And
of the
people have to do what in order to get into this?
Nothing.
Just be
It's just the county that's going
the
to
county
pay.
is doing this.
Yes, nothing. Nothing.
There are less than 10 days to go,
Yeah.
Governor, for the shift to SHIF. Now, of course, you need to see that your health facilities in Murang'a, from level 1, 2, 3, 4, all the way to 5, you have level 5, right?
Yes.
That all of them are then now ready and integrated to the migration, so that when your people go to seek health services in any of these facilities, they will get the services. Is that happening?
Yes, as we are ready, I think it's the Ministry of Health that we are hoping it is ready.
Is SHIF ready?
I don't know. I really don't know. I hope so. Let me
Okay.
say I hope so. I hope they are ready.
Maybe I should ask it at Council of Governor level, right? This transition from beginning of next month, how is it going to work? Because all these facilities are actually managed by the county governments.
Practically, services will run. What might tax our minds in the worst case scenario is the funding. Who pays for our services? So I think Kenya should not panic to the extent that SHIF or even HIF does not offer medical services. It is the counties that have doctors, that have medicine, that have all those things. Probably I would worry if the private sector now refuses to offer services on account that SHIF is here to be settled well. So us will continue offering service. The question that we might grapple with is who compensates us for this service. Yes.
What conversation have you had with the national government? Because there are 3 tiers in service provision now with the Social Health Authority. There is the primary healthcare bit that is 100% taxpayer funded, where you're telling somebody pick a village in Murang'a, Kamasharia, and they go to a dispensary there. They should go to a dispensary in Kamasharia and go back home.
Treated without paying a dime.
Yeah. If you are traversing Murang'a and you're involved in an accident, you should go to a facility and the emergency care cover should sort you out. Again, taxpayer funded. Are those aligned?
We had a meeting with them, I think it was last week, when and they seem to be suspending some of those benefits. I think the one for emergency seems to have been suspended. They want more timelines to be able to transit into that area. So probably we wait and see what happens. But it appears the main package is ready. And from where we see it, and I would imagine all counties have the same philosophy, we should not create a notion among the people that if SHIF is not ready, services will grind to a halt. What I would suspect might happen if SHIF is not ready is services are offered, counties are now fighting with SHIF for reimbursement. I think that would be the worst case scenario. It will be fight with the element of reimbursement.
Okay.
Yes.
There's a piece of legislation called the Facilities Improvement Fund, right? That says that now we are ring-fencing money within facilities so that it can improve those facilities. Facilities are run by counties. Are counties ready? And for example, is Murang'a doing that? Is Murang'a ring-fencing money from specific facilities so that it goes on to improve those same facilities?
Yes, we are. We came up with a system, an automated platform, which basically is with all the 8 hospitals. They can now procure through that system. So meaning if you raise a requisition, it goes to the platform. Then there are certain approval levels from the Director of Procurement, Chief Officer, Health, and then an LP is generated and goods are delivered. So far, it seems things are working well. We have seen several things. Number one, revenues have gone up because now the people who are heading facilities are a little bit better motivated because they know whatever they are generating remains in the hospital. Also, the automation has made it a little bit simpler for things to get to the hospital. So from where we see it, things look better. A good example is Murang'a Hospital.
Okay. How much does Murang'a County owe KEMSA?
Let me first finish that. Okay. So Murang'a used to generate, I think, per month about 1.6 million Kenya shilling.
Murang'a Hospital?
Yes. Currently, we are now doing 10 million, headed to 11 million.
From 1.6?
Yes. That money is now retained as the hospital or the main hospital.
It stays in hospital and continues to operate?
Yeah. Same way you find like Kenneth Matiba, who is now generating about 1 million Kenya shilling. Maragua used to perform very poorly, about 1 million Kenya shillings per month. We are now doing 4 million. So the point is, I think those people who superintend those hospitals, now they have better cash flow to deal with the problems that arise in a hospital. We are no longer controlling that money at the center. How much we owe KEMSA? Last time I checked, it was about 19 million. But the figure keeps on fluctuating. But we are among the best counties in terms of owing less to KEMSA. Yeah, but of course, I'm not saying 19 million debt is good. No, we need to clear that debt. But we have been strong supporters of KEMSA. But once you request KEMSA for drugs, probably they will be able to fill 60%, 40% they will not be able to fill. So we have engaged a Catholic Church-owned supplier called Meds. So Meds is able these days now to plug into the system and be able to supply us drugs at our hospitals. Of course, there are also instances where we do get it from private, but that tends to be the last resort. So the first is usually KEMSA. If KEMSA, okay, Meds. If Meds, private. Yes.
Okay. There used to be talk of a lot of people who would leave the dormitory counties of Nairobi, Murang'a being one of them, to come to Nairobi for specialist care. Since Kang'ata Care came into place, do we see that specialist care now is available and can be operated within the county and you don't have to leave to get it done?
Yes and no.
Okay.
Let me start with no. Nairobi still retains the uniqueness of having the best healthcare in some areas. Take, for instance, cancer management. I think definitely Murang'a needs to work on that. I see a lot of people coming to, let's say, Texas Cancer Center in Nairobi with the card of Kang'ata Care. You know, we usually get the reports. So quite a number of our patients come to Texas or KU Hospital or Kenyatta seeking those very specialized care. Yes, but not because of Kang'ata Care per se, because of other factors. Like, for instance, Murang'a has introduced something we call telesurgery. Telesurgery means you can now be operated in Murang'a by a surgeon, but there are other doctors who are helping when they are far away through the internet. So a doctor has a gadget fixed, and when that gadget is able to look at the operation room, and the other stakeholders who are able to contribute to that from far, that then boosts the presence of expertise in Murang'a. Yes, also to the extent of also telemedicine. You know, telemedicine is the lodge. We have introduced telemedicine in about 13 rural health facilities. Today, another 10 will start doing the same. That will be about 23. Patients with these chronic ailments used to travel all the way from the rural Murang'a to Murang'a level 5, because that's where you find, let's say, a cardiologist to get treatment. And you know that costs you about 1,000 to reach Murang'a. Then you have to eat lunch. You lose a whole day.
It's a cost.
It's a cost. So we came up with telemedicine. The idea is when you are far, let's say in Kigumu, you go to the nearest facility, you talk to a doctor who is in Murang'a. He gives you that care. Then you don't have to travel to Murang'a. Probably we think if we upscale that, we'll now get to the expertise in Nairobi. Maybe even in India, maybe years to come, maybe even in America, years to come. And also, yes, to the extent we have some partnership with some European doctors in Maragua. There's a doctor, Dr. Victoria is a Spanish doctor who lives in Maragua Hospital. He has an organization which brings European doctors, and they offer specialized surgeries in that hospital biannually. They do plastic surgery. Yeah. So they were there from, I think, from Europe 1 week ago.
Okay. Governor, we thank you very much for coming. I wanted to ask you a question about, the relationship with the national government, particularly in the delayed disbursement of funds and how that affects service delivery at county level. But that's a conversation for next time.
Thank you.
Asante for coming.
Thank you so much.
Dr. Irongo Kang'ata is the governor of Murang'a County. He's been our guest. Keep it here for more. In the next hour, we talk about the UN